Hello, and welcome to a very special Facebook Live broadcast with MedStar Health. My name is Karen Zingle, and today we will discuss a very important topic, prostate cancer screenings. September is Prostate Cancer Awareness Month, and did you know 1 in 8 men will develop prostate cancer in their lifetime? The good news is that early detection is key to beating any form of cancer, and knowing your risks can determine if you need to be screened. I'm joined by several experts from MedStar Georgetown Cancer Institute. So stick around, share this broadcast with your friends, and if you have questions for our experts, leave them in the comments below and we will answer them during our broadcast. So thank you for joining us. Thank you to our experts. Let's start by doing some introductions and then we'll get into some questions. So let's start with Dr. Hwang. Dr. Hwang, can you introduce yourself to our viewers?
Sure. Thank you, Karen. I'm so delighted to have this opportunity today. I'm Dr. Jonathan Hwang, Chair of Urology here at MedStar Georgetown Hospital Center, and has been specializing in prostate cancer management for past 15 years. And delighted to be here today.
Thank you. Dr. Collins.
I have the best job in the world. I get to work here at Georgetown, and I take care of older men. I learn more from them than they learn from me. Every day I look forward to my job and getting up, and thank you for including me today.
Wonderful, thank you. Dr. Kowalczyk.
Yeah, hi, I'm Keith Kowalczyk. I'm chair of urology at Georgetown, and also, like Dr. Hwang, urologic oncologist specializing in prostate cancer. Absolutely happy to be here with a great panel of people that I work with on a regular basis. So it's really fun to be here.
Thank you. And Dr. Leger.
Thanks, Karen. And my name is Paul Leger. I'm a medical oncologist at MedStar Georgetown University Hospital. And my main focus is on prostate cancer, treatment of prostate cancer. I'm very, very happy to be with you today.
Thank you so much to all of you. So we have some questions. And again, viewers, if you have questions about prostate cancer screenings, please ask them in the comments and we'll ask those during our broadcast. So Dr. Hwang, let's start with you. Is prostate cancer common?
Yes, I'm so glad we're addressing this issue this month being Prostate Cancer Awareness Month. You know, as you mentioned, 1 out of 8 men will be diagnosed with prostate cancer in their lifetime. It remains the most common non-cutaneous cancer in men. This year alone, or every year, there's approximately 175,000 men who get diagnosed with prostate cancer. So clearly, this is something that every man should think about after they reach a certain age.
Thank you. Dr. Kowalczyk, what about men being diagnosed? What does the survival look like?
Well, like you said before, I mean, the key here is early detection so we know what to do. We certainly had issues with overscreening with prostate cancer that made headlines. But you know, we really went the other way, where a lot of men are now being unfortunately diagnosed too late when it's hard to treat. But if we're able to get somebody very, very early on in the process, we can determine whether they need treatment or not. And if they do need treatment, you know, as we'll discuss, there's so many options that survival is very, very good when found early and at a treatable stage.
Thank you. Dr. Collins, can you talk about how in many cases, someone who has prostate cancer, can you talk about how it grows over time?
You know, prostate cancer grows really slow. I am 52 years old now, and this is September, so it's football season. So every football season, I get my digital rectal exam and my PSA checked. And I remember it because it's always when the Washington team plays their first game is when I get my digital rectal exam.
That's great.
I'm not anxious about it. I go because I know that this is a process, that it's important to get checked every year, but in any given year, it's unlikely that I'm going to have prostate cancer. So over the next, hopefully I'll live 30 more years, I'll be seeing either my primary care doctor or my urologist, getting my PSA. I usually do it once a year. You don't have to do it more than once a year. Eventually, everybody in my family gets prostate cancer. I'm not worried about it because they all get cancer, they get treated. We have the best team here at Georgetown. I would let Dr. Kowalczyk or Dr. Hwang operate on my prostate if I'm a young guy. If I'm an older guy, I'm getting radiation here at Georgetown with the CyberKnife, but we'll see what happens. Hopefully I'll get it later rather than sooner. But if I get it sooner, I know that I'm in good hands.
Thank you very much. Dr. Leger, can you talk about aggressive prostate cancer?
So prostate cancer is usually considered as a slow growing, as Dr. Collins just mentioned, like an indolent cancer. For example, many men may have prostate cancer and never have any symptoms or never require any treatment. However, there are also some patients may have some aggressive or high risk disease. Some of the features of high risk, for example, if you have a prostate cancer with a very high PSA, what we call the PSA, for example, if you have a PSA of more than 20, you're considered as having a high risk disease. Or when we look under the microscope, there are some features that the pathologist may look at the cancer. Some of the features, for example, we have a classification, this is for physicians, that we call the Gleason score, for example. If under the microscope you have these high risk features with a Gleason score of 8 or 9 or 10, you're considered as having an aggressive or high risk disease. And aggressive prostate cancer should be treated aggressively, otherwise may lead to death of patients. So definitely you need to follow up with your doctor and get the right treatment for your disease.
Okay, we might have lost Dr. Leger. That's okay, that happens sometimes. So Dr. Kowalczyk, can you talk about maybe picking up on what Dr. Leger was saying and also talk about family history and the BRCA1 and 2 genes and that risk for prostate cancer?
Yeah, so I think Dr. Leger mentioned, it is a disease of older men. So as we get older, we're at increased risk. Doesn't necessarily mean that it will be the high risk disease that he talked about, but as we get older, it's riskier to get prostate cancer. The patients that we really want to screen every year, and not everyone needs to be screened every year, but the people that do are those with a family history, and that's a primary family history. So a household, father, brother, that puts you at 2 to 3 times increased risk. Talk about African-American men are at very high risk, and there are disparities there as far as access to care, but additionally, they are at higher risk of prostate cancer. And now there's more focus on what we call germline genomic, germline gene mutations. So BRCA1 and BRCA2 are normally seen as ovarian and breast cancer genes, and fair enough, that's what they're named after, but we're finding that men in these families are actually at risk of prostate cancer and high risk prostate cancer. So these are the men, family history, African-American men, BRCA1, BRCA2 mutation. There's even a few others, but those are the men that we really think need to be screened every year and potentially even earlier than 50. Men without those risks can talk to their physicians on a case-to-case basis to get it checked semi-annually, and that would be men between the age of 50 and 70 for the most part is where we really want to catch that.
Okay, thank you for that, and welcome back, Dr. Leger and Dr. Hwang. Question I'm just going to put you right on the spot when you come back, Dr. Hwang, and ask you a question about our risk factors. Can you talk about other factors like smoking and obesity and how that puts you at risk for prostate cancer?
Absolutely. I think these are 2 areas where men can actually work on preventative measures. So for example, smoking has been associated with a higher incidence as well as mortality from prostate cancer. Obesity is very interesting in that it may be somewhat protective in terms of being diagnosed with prostate cancer. But on the other hand, men with obesity tend to be diagnosed with high grade or high risk prostate cancer. So certainly these are the 2 areas that men can work on.
Thank you very much. Those are wonderful. That's wonderful information for our viewers to make sure that they understand their risk factors. Let's talk about the specific PSA test. So Dr. Kowalczyk, could you talk about what is a PSA test?
Yes, I would love to. So a PSA test is a simple blood test. It's very easy to do. It can get done with any other normal testing you're getting done with your primary care physician. And that's what we use to screen for prostate cancer. It's one of the only blood tests that we have that can actually screen early for a cancer. The issue is the PSA stands for prostate specific antigen. And while it is specific for prostate tissue, it's not prostate cancer specific. So that's where it really takes, a second opinion from one of us to see if a PSA that's elevated really meets the criteria for that next stage, which is, do you need a biopsy? Do you need further imaging or anything like that? But PSA test, it's just a simple blood test. That's not the hard part. I think the hard part is interpreting it for each patient to see whether you have to go on to the next steps of prostate cancer screening.
Thank you very much. Can someone talk about the process for getting one? How long does it take? What type of experience would someone have when they go in for their PSA test?
Well, I can talk about that because I go every September.
Yeah,
it's very
just
easy.
that, right?
I usually get to work at 8 in the morning. On those days, I usually come in at 7. I just stop off at the local lab. They poke my arm. They take a little bit of blood. Takes probably 15 minutes to do. Usually my doctor calls me back about 3 days later and tells me the result. My last PSA was 1, and the doctor told me that that was appropriate for my age of 52. And she told me that I just have to check it every year. I do have a family history of prostate cancer, so I am at elevated risk. So I get my PSA checked every year.
Thank you for sharing that. So it sounds like it's pretty simple and
really simple.
A neat, simple blood test, doesn't take very long. What about insurance? Is it covered by insurance when a patient has specific eligibility criteria?
Never had a problem.
Yeah, I believe for annual screening, they do allow 1 test a year. Now, that's men with average risk or without any urologic symptoms. We also see many men who walk in having some type of urinary symptoms. I think in those men, we are allowed to order a follow-up PSA test as needed. So, but certainly 1 a year for men over 50 years of age is covered by most insurance.
Great, thank you for that.
I would say one question that I often get is I have patients in the afternoon who I say I'm going to check a PSA on, and they say, well, I haven't been fasting, because they're often told that they need to fast for blood tests. That's not the case for prostate for PSA either. It's not a fasting test. They used to say you can't do rectal exams before PSA. That's not quite true. Sometimes you may want to avoid biking, sexual activity, 24 hours before, because that can throw off the test as well. So there's little caveats here that could skew your PSA. But like Dr. Collins said, it's a trip into the lab, no more than 15 minutes.
Wonderful, thank you for that. So yeah, it sounds like an easy way to keep an eye on your health and make sure that you detect, if you do have prostate cancer, you detect it early. Because early,
know than not know.
Yeah,
I'd rather know than not know. I'd rather have the information and then I can make a decision.
exactly. Yep.
Really.
And I love, Dr. Collins, how you have a specific, there's always that reminder. It's football season. It's time to get my PSA test. I love that. I think that's a wonderful way to keep that reminder there, tying it to something that you enjoy. Maybe it's a season or really any way to send that reminder to yourself, because a year can go by pretty quickly. So you got to make sure you stay on it. Can we talk I want to talk a little bit more about misconceptions about the PSA test. Dr. Kowalczyk, there's a lot of just myths in general about who should get a PSA test. Can you talk about the folks that should go in and go through this process?
Yeah, I don't know if it's myths more than because the headline, without looking at the fine print, was that it wasn't a good test. And that's just simply not true. It is a good test. Again, it's the only blood test we have to screen for cancer right now. That being said, those who should get it are the ones at high risk that we discussed: the family history, African American, BRCA1, BRCA2 genes, which ties into family history. And you should start getting it depending on your risk between 50 and 70. Some men can get it, what's called a baseline PSA, in their 40s. That's something I advocate, because we always see a patient with high-risk cancer that we would not have expected, who does not have any of those risk factors. And data has shown that if you just check a PSA in your 40s, if it's below a certain number, if it's below 1, your risk is very low. If it's above 1, your risk is a little bit higher, so you can continue checking. And that's something I did myself. I'm in my 40s. Thankfully, mine was 0.6. So I probably won't get it checked again until I'm 50, but so I think the myths are, it's not a bad test. It's just a test that requires interpretation by an expert, and no one should have a knee-jerk reaction off of one test.
Thank you very much. Who should not get a PSA test?
Well, clearly, I think men over 70 years of age, unless they have certain risk factor like positive family history, you really need to discuss pros and cons and see whether PSA test is appropriate. Any person with a life expectancy less than 10 years, probably unlikely to benefit from prostate cancer screening.
Okay, thank you. Dr. Hwang, can you talk about the PSA levels? Dr. Collins mentioned his levels earlier. Can you talk about what that level indicates or what it doesn't indicate and what's considered normal?
Right, so the current standard is the level of 4 or below. And there is some paradigm about using age as possible adjuster for PSA level. As many men, as they get older, their prostate enlarges, their PSA level naturally go up. But currently 4 is the absolute cutoff. But as Dr. Kowalczyk mentioned, we don't just react to one PSA level being mildly elevated. We like to account for patients' history, their age, their life expectancy, and then decide what the next appropriate step would be, whether it's active surveillance or simply getting a follow-up PSA test at a later time.
Thank you very much for that. So we've talked about risk factors. We've talked about the specific PSA test. So I wanted to just pause and take a moment to thank everyone who has been joining us on our Facebook Live. As you may already know, September is Prostate Cancer Awareness Month, and we have experts here from MedStar Georgetown Cancer Institute, and we're talking about risk factors, screenings, what to expect when you get tested. We have more to talk about, and we have some questions from our viewers. So I'm going to get to those. And if anyone has any additional questions, please share those in the comments. So starting with some questions from our audience, and whoever wants to take these, feel free to jump in. This one's from Terry. This is a good segue. He talked about his levels. 61-year-old, he's 61 years old. He also has a brain tumor, and his PSA level is 4.40. Should he go see a doctor and have a conversation about that?
Let me talk about the brain tumor first. Brain tumors are very variable in their prognosis. Some brain tumors have very good prognosis, and you can have more than 10 years of life expectancy, while unfortunately other men are diagnosed with high-grade brain tumors, and their life expectancy is short. So meeting with both the doctor taking care of next time he sees his doctor taking care of the brain tumor, I would ask him what his expected life expectancy is. Stare the doctor right in the eye and look him straight in the eye and say, "Doc, how many years do I have left?" If it's more than 10, like if he has a meningioma or he has a low-grade glioma, then I think discussing the next step with the urologist is the right way to go.
Okay, thank you very much for that. Thank you for your question, Terry. We have a question for Tim, from Tim, and this goes back to the kind of the risk factors and the age. He is 57 and unfortunately was diagnosed with prostate cancer. He's asking why so early? I know he mentioned some risk factors, maybe some risk factors tied into that, but any advice for Tim?
Why so early as far as his age, being young?
I think so, yeah.
Yeah.
Mm-hmm.
So actually that's within the realm of normal age to be diagnosed with prostate cancer. Hopefully it's a very early stage, very treatable if it needs to be treated. We see so many patients, we see people who are 40 with prostate cancer, and 57 is a very young age still. Definitely most likely without knowing anything else. That average 57-year-old has very good life expectancy. So it all depends on the details of the cancer. where should go next, but definitely should go see a urologist, radiation oncologist, everyone about all of his treatment options. But 57, doing enough prostate cancer, that's around the not quite, a little bit below average, but that's not a surprising age.
Thank you. We have a question from Ivan going back to those PSA levels. He has a question. What other reasons besides cancer are there for a high PSA? So you have a negative biopsy and a great MRI, but still have a high PSA level. What are some reasons why that could be the case?
So I would say that two most common causes for PSA elevation is actually not cancer. Number one being benign prostate enlargement. So we see many men, especially entering into their 60s and 70s, will develop some symptoms or possibly asymptomatic BPH, and that will usually correlate with a higher PSA level above 4. And the other one is inflammation. Any kind of inflammation, it could be symptomatic inflammation. Some men can have transient inflammation that may be minimally symptomatic. In those men, typically their PSA will spike up. And then when we follow that PSA over time, the PSA tends to come back down to their baseline level.
Okay, thank you very much. Another question from our viewers from Norberto. How high is prostate cancer for Hispanic community?
It's a good question. Hispanic community tends to be probably about average risk. African Americans are highest. Asians actually have a lower risk. And the Hispanic community, I see a lot of Hispanic patients with prostate cancer, but I wouldn't consider them at higher risk. I do think, we mentioned healthcare disparities with African American men. We've seen that certainly some of my studies with bladder cancer as well as prostate cancer in Hispanic men as well. So there may be some access to care issues in the community, but overall, average risk.
Okay, thank you very much. Question for you about going back to the test. I don't think we've talked about this earlier. Are there any side effects once you go in and get the PSA test?
The biggest risk of PSA screening is not the test itself, it's how it's interpreted, and hopefully it's interpreted correctly.
So that's why you should always have a follow-up, a good discussion with your physician, either your primary care physician, your urologist, to figure out how to interpret it.
Right, and if a primary care physician has any questions about a high PSA or low PSA, we're happy to go in and take a closer look. We have some fancy other types of things that we can do to see if it is because of BPH, like Dr. Hwang said, or if it is because of prostate cancer. So it's not the test, it's the interpretation. Most PSAs are checked by primary care physicians and not urologists. Over 80% of PSA screening is done by them. I just think it's important that if there are any questions, don't hesitate to see a urologist to really interpret it, probably recheck it. We're not itching to biopsy people by any means. We want to take another closer look at it.
Thank you very much. That's a good segue to the next question, just in terms of your results. If you have an elevated PSA level, what is the next step? Dr. Hwang, do you want to take this one?
Yes, so obviously when we see them in office, we'd like to take a detailed history and perform a digital examination. And then really have a candid conversation with men about pros and cons of further screening, whether that is simply repeating another PSA level or proceeding with an imaging study like the MRI. But as everybody have said thus far, that clearly our goal is not to overreact and biopsy everybody, but try to really identify those men who are truly at risk of potentially having high-risk prostate cancer, and then guide others, maybe a more conservative approach.
Thank you. Dr. Kowalczyk, can you talk about the specific diagnostic tools and biopsies that are available?
Of course. So like Dr. Hwang mentioned, multi-parametric MRI. So this is not like an MRI you get in the community. It's not open MRI. It's a very, very strong specific MRI called multi-parametric MRI. Has really changed the landscape of diagnosis and treatment of prostate cancer over the last 10, 15 years. A lot of the work done by our friends up at NIH. So we can really, if someone has a high PSA and we're not quite leaning towards biopsy, or we're not quite sure, an MRI can help us decide whether that's the next step needed. So MRI won't pick up all cancers, but it will pick up the majority of the high risk cancers, the ones we're talking about that definitely need treatment. So if someone has a negative MRI, we might say, okay, let's just recheck a PSA. We don't have to biopsy. Whereas if there's concern, we would go ahead and do the biopsy. And we can also use that MRI to guide our biopsies as well. Not all insurances cover MRIs, so especially if you haven't had a biopsy yet. So we do have other tools. We have something called a free to total PSA ratio, which is just an add-on to the PSA test, which we can help interpret to see if it's a real rise in PSA due to BPH or due to cancer. There are other, what I like to say, is second level PSA tests like 4K score, PHI, which are, you know, that gets kind of down into the weeds, but a little bit more specific for prostate cancer. And then if it gets to it, if we do decide to do a biopsy, like I said, we can use the MRI to guide it. And one thing I'd like to mention is Dr. Hwang and myself and the entire MedStar urology, you know, between Georgetown and Washington Hospital Centers, we do what's now called the transperineal prostate biopsy, which avoids any risk of infection. And in our experience gathering our data actually has increased, biopsy discovery. So we think we're right on the forefront of all of these things.
Wonderful. Thank you for that. Dr. Collins, can you talk about, so if you have an elevated PSA level, you're having these conversations with your physician team, and you're ready to explore treatment options. Can you talk about what someone would do if they are exploring the options for treatment?
What usually happens is most patients are diagnosed by a urologist, and usually the urologist they'll do the biopsy, they'll come in for an appointment, and they'll explain the different options for them. One of the things I'm proud of, MedStar Georgetown Hospital, is that every patient sees a urologist and a radiation oncologist, and we discuss the different options. So in general, younger men who have long life expectancies, like if you have like a 30-year life expectancy, you might choose surgery over radiation because it removes your prostate. After radiation, you still have a prostate in place, so you can have recurrences. So generally, younger men have surgery. They have less side effects from surgery, and older men usually get radiation. In my opinion, the preferred option is to do active surveillance if you can. The best way not to have side effects from treatment is to not treat people. So if you go through a biopsy and you're found that you have a low-grade cancer, our urologists are very good at doing active surveillance, which basically means monitoring you every year or so, maybe doing a biopsy every couple of years, an MRI every couple of years, and not treating you unless you need treatment during your natural life expectancy. We have a tumor board that's run by the urology department where we discuss cases twice a month. And I would love to hear Dr. Kowalczyk's opinion and Dr. Ledger's opinion on how effective that tumor board is for helping counsel patients.
You want to take that?
Yeah, no, I'm happy. I mean, so Dr. Leger, Dr. Collins, and I, and Dr. Hwang also has tumor board over at Washington Hospital Center, which I was happy to be involved with today. That's always a great option because we all put our heads together for patients that might not, it's not medicine is not cookbook, and we work as a team, and I need to know what other people think, and is this patient eligible for radiation or not? We also have the radiologists that look at the MRIs to tell us, is this really a high risk lesion? Does the biopsy make sense with what it looks like on MRI? So we all put our heads together to figure out what we think is the next best thing for the patient, because none of us, we're experts together, but I wouldn't, I always want to know that these three other guys have my back. So that's very helpful in counseling patients. Usually I'll let patients know that we're presenting them at the tumor board. So I don't want to freak. Doesn't mean that this is crazy. It's just, but it also, if say I'm going to hand over care to Dr. Collins or Dr. Leger, right away they have an appointment. It'll get set up because we've talked about their case. So it's nice, and we have that at both MedStar Washington Hospital Center and MedStar Georgetown University Hospital.
Can I bring up one important point?
Yeah.
So it's not about just like the MRI, it's really the interpretation of the MRI. So the radiology department, both at Washington Hospital Center and at Georgetown, are spectacular. I think their reads are very helpful. They clearly take a lot of time looking at them. When I call them or email them, they're eager to explain to me something that I might have missed or might not have understood. So definitely, it's not just about doing an MRI on a patient, it's having the right team with the right machines. And at MedStar, we have the right team with the right machines to interpret your MRI.
So,
And
so what we call the multidisciplinary team approach, and this is what we promote at MedStar Georgetown University Hospital, where you can imagine you have sitting at the table, you have the surgeon, the medical oncologist, the radiation oncologist, you have the radiologist and the pathologist, all of us together to review the case and discuss and try to tailor the treatment to come up with the best treatment option for the patient. I think this is a wonderful experience for our patients, because when all of us can come up together, we definitely come up with the best treatment options for the patient. And we have that every other week. We sit down together and we discuss options. And I think it's one reason I think make our strength and why we can provide the best care possible to our patients.
Thanks, Dr. Leger. So the team itself is a wonderful resource for our patients. You are coming up with those treatment options, the best treatment option for their specific case. You're having conversations about it. I think that is a wonderful resource for our patients, and certainly probably the best one. Are there other education resources that patients could turn to if they are diagnosed with prostate cancer?
Yeah, I think there are several national, organizations that provide, free information. For example, American Urologic Association, American Cancer Society, National Cancer Institute. So I think these are all very reputable websites that try to give unbiased opinions or as accurate information about what is current in terms of prostate cancer management and screening. So I always encourage men to explore those options.
A lot of the handouts I use come from urologyhealth.org, which is it's a Urology Cares Foundation from the AUA, and they have really excellent patient guides, even through PSA screening and for benign things too, which they don't get into the details, but give patients a very good overview of what's available. So I think that's the NCI has a fantastic website that I love, and great patient pamphlets too. It tends to be a little bit more detailed, I think. But so it depends on what you're looking for. But those are the two, like Dr. Hwang said. I believe it's at cancer.gov for the NCI patient information, and then you have to scroll down and go to prostate cancer or urologyhealth.org.
I agree with you. There's so much information out there over the internet. And I think the American Urological Association website, you will find a lot of great resources. However, I'd like to point out, I think the best source of information is to discuss with your provider, your trained professional, either your primary care, your urologist, or your medical oncologist, because when you get flooded with all of this information, we want patients to make the best decision. And having this discussion is key, I believe.
100%. I think those pamphlets are more, they'll give you an idea. It's like learning a new language. You get diagnosed with prostate cancer. I tell my patients, you tell one of your friends, and all of a sudden you're going to find 5 of them that are going through the same thing. And you're going to start tossing around your PSAs and your Gleason scores like at the poker match. So these handouts are good to kind of, I guess, quote unquote, learn the lingo, because, Gleason score, PSA, what does all of that mean? Usually when I have a patient that I diagnose, it's 30 minutes of just explaining what all of this means before we can even get the treatment option. So that's where it's helpful, is to kind of learn where we're coming from. And then like Dr. Leger comes in, then have a frank discussion with all of us really on where we should go next.
Thank you very much. That's really helpful. Yeah, obviously having the education and the team behind you is really the foundation for how you can move forward and get through your treatment should you be diagnosed with prostate cancer. But we definitely had really started the conversation by talking about screenings and the PSA test, which I think is the first step to knowing whether or not you are going to be going down that path to treatment. Can someone talk about where the PSA tests can be, where can you get them? And I know we talked about how the primary care doctor also is involved. in that and reading the test. But I want to make sure before we wrap up that one of our takeaways is, where do you go to get the PSA test to really start that screening process?
I think there are two options that men can use. I think one is really have a frank conversation with their family doctors, whether to include a PSA blood test during their annual checkup. So that will be one option. And for those men who like to get a little bit more advanced information, they can certainly set up a consultation with any urologist, and they can get ample information about pros and cons of screening and to proceed with a PSA test if appropriate.
Thank you. So we do have one more question from our audience. Well, one comment that I'll share first from Lorenzo. I think MedStar has the best team for prostate cancer. So thank you, Lorenzo, for that comment. We have a great team here at MedStar Health. So thank you for that. I don't know if Da Vinci treats prostate cancer. If you could address that.
That's actually really funny. They're both robots.
Okay.
Dr. Hwang and Dr. Kowalczyk use Da Vinci. The CyberKnife is also a robot.
Right. So we're talking before what it depends. Every patient's different. There's multiple treatments for prostate cancer, but to keep it simple, it's surgery or radiation are the two big ones. And it's younger, healthier guys that tend to get surgery. It's older, still healthy or unhealthy guys that tend to get radiation. Dr. Hwang and myself perform robotic, or if you want, Da Vinci prostatectomy. And that's a wonderful tool, but the tool is only as good as the surgeon, number one, because the long-term side effects of prostatectomy can be incontinence and erectile dysfunction unless you're with an experienced surgeon. Dr. Hwang has done the most in the area. I'm right up there. I've done over 1,000 now myself. So both of us are very facile doing this, and thankfully have very good outcomes. But like I said, it's not the robot itself. Someone like Jordan Spieth can hit a ball with a driver 360 yards, and I can use the same driver and I'll miss the ball. It doesn't really matter what driver I have. So it's the same thing with the robot. Dr. Hwang and I are very, very experienced surgeons, so I think that's the most important aspect of picking a surgeon. At the same time, we work as a team. Dr. Collins is a wonderful resource because if I have any patient, I offer every patient a consultation with Dr. Collins because they should know what all of the options are. And a lot of times it'll be very clear cut what they should get, but I still want them to hear from him. And Dr. Collins, all I do is give him a call and he sees them right there. So it's one of the wonderful parts about working with these guys.
Yeah, I mean, I concur with Dr. Kowalczyk's statement. Dr. Kowalczyk, is one of the top robotic surgeons in the area, really pioneering this new technique that's leading to faster recovery in terms of continence. But, overall, like the type of cancer or the stage of cancer has also a big impact on the successful outcome. But I will say one thing, and it's whether Dr. Collins has, Dr. Kowalczyk, or myself, when we look at prostate cancer outcomes, it's not only cancer cure, understanding that that's the utmost importance, but at the same time, our goal is to make sure that we protect your quality of life in regard to your bladder function, sexual function, bowel function. So, one thing I am very proud of is to be part of this team, and you will get certainly one of the best cares that one can get for prostate cancer treatment at MedStar.
I wouldn't be frightened about, having prostate cancer, having any kind of cancer is, of course, going to be a big deal in your life. But we're making great progress in making the care of prostate cancer much simpler with less side effects. If you have surgery for your prostate, what are you in the hospital for one night now? and then
one night we're working on same day.
Same day.
Yeah.
There's a recovery period, but it's the continence results with the robot seem to be outstanding from my point of view when I see them. If you need radiation, we have the most advanced radiation in the world. We have CyberKnife. We've had it since 2001. We're one of the most experienced centers in the world. We were the first center in Washington, D.C. area to get a proton machine. We do brachytherapy. We have IMRT. So whatever situation you're in, we have the tools that are required to fix it. A lot of these guys are getting older and they're still working. I don't know. I have patients now that are 75 years old and they're probably the busiest they've ever been in their careers. they don't want to come for 8 weeks of daily radiation. They want to come in, get it done. So instead of doing 8 weeks of daily radiation, now we treat them with 5 large doses of radiation. The outcomes are equal or even better than the previous radiation, and it's a hell of a lot more convenient for the patients. Our patients should be spending time with their families. They should be traveling, seeing the world, taking care of their grandkids. They shouldn't be sitting in our offices getting cancer treatment in the prime of their lives.
Thank you, Dr. Collins. That's a wonderful final message for our viewers, a good takeaway. Dr. Leger, any final thoughts from you that you'd like, what would you like our viewers to walk away with, especially those that haven't had a PSA test or perhaps are dealing with prostate cancer?
Thank you for this question. I would like to address specifically a simple word to African Americans who may be watching this program. We have a huge health disparities for this disease in African Americans compared to other population, and I think we mentioned that a couple of times. But let me tell you just one number. If you have prostate cancer, African Americans have like 2 to 3 times higher risk of dying of the disease compared to if you're a Caucasian or other population. And these health disparities are probably from so many reasons, like social or economic reasons. So what can we do about it? I think there are a couple of things you can do. The first thing is to get educated, to get informed about the situation, because knowledge is power. The second thing, get screened or encourage your loved one to get screened, because early detection, early treatment is key. The thing to remember, early detection, early treatment is key. Let me give you a number. If you get early treatment, you have 95%, more than 95% chance of being alive 5 years later, compared to if you get treated at an advanced stage. I'm a medical oncologist. When Dr. Kowalczyk or Dr. Collins, when they do their magic, and when things get complicated or more advanced, they refer the patient to me. So when I intervene, when we get to this advanced stage, usually only 30% of my patient will be alive 5 years later. So the key is early detection, early treatment, because with that, if there is one thing I would like people to remember, if you get screened, you get treated early, you have more than 95% chance of being alive at 5 years, compared to 30%, only 30% chance of being alive at 5 years if you get treated at a more advanced or later stage of this disease. So that's the thing I would like them to remember.
Thank you very much for that important information for our viewers to take away. Dr. Hwang, I know we have to let you go in a minute so you can go see your patients. Is there a final message you'd like to share with our viewers before we wrap up?
Yeah, so Dr. Kowalczyk and I were making great efforts to make ourselves and our partners, colleagues readily available for any man interested in prostate cancer screening or learn about prostate cancer treatments.
Thank you very much. Dr. Kowalczyk, anything else from you before we wrap up?
Well, number one, I think, like Dr. Hwang mentioned, we have probably the most experienced team in the region as far as prostate cancer treatment goes, as well as prostate cancer volume and surgeries. So, we treat a lot of patients like this, and I think we do it in a very compassionate way and a very unique way. I want to reiterate what Dr. Leger said as well. Is one of my favorite things when they're seeing myself and Sean and Jonathan. We're seeing these early stage prostate cancers. And one of my favorite things to say is you're going to have to go through treatment. If they're not getting active surveillance, you're going to have to go through treatment, but 99% cancer survival if we treat it early versus, if I see patients with high risk, we still may operate, we still may radiate, but they're also going to need, more advanced treatments with Dr. Leger. And that may have been prevented by just checking the PSA 5 years earlier. So the one thing is if you get it checked early, your survival is excellent. And getting it checked early at the same time does not necessarily mean you'll need any of these treatments. It's all about discussing with us as the team, what your best option is. As Dr. Collins said, my favorite thing to recommend is active surveillance. So if that's what we can do, that's what we'll do.
Wonderful. Thank you so much. Dr. Collins, anything else from
One
you?
more
Any
thing.
final words?
Yep. So we're actually lucky that we have Dr. Lejeune. One of my favorite things is when a patient who has a genetic history or a family history comes and sees us, we have the best genetic counselors for helping people like that. We also have the best medical oncologists, and I think I'm blessed to work in such an amazing place. And thank you for doing this today.